Hi, I'm Mark Phillips. I'm a hand and wrist surgeon working in London. Uh, I have developed a subspecialist interest in treating musicians, and I'm also a very keen musician myself. I play trumpet and in a local jazz quintet here in Greenwich. And I really enjoy looking after musicians. There aren't many of us in the world as hand surgeons that have a specific interest in looking after musicians. And this particular interest fell on my lap a few years ago when John White moved from London to Australia, where he developed a large musician's hand practice in North London. And he went off to Australia about 3 years ago, where he continues to practice. But here in London, I then inherited a practice off Ian Winspur. It's been an amazing ride, and I have really enjoyed learning all about it. I'm going to take you through a little talk I give on the subject now, which is coming up here. I'm just going to do a screen share with this. Okay, and it would be better if I do this like this, I think. Good. And I'm often asked this thing: is musicians' hands a subspecialty of hand surgery? And I think it is. I'll tell you why I think it is a thing, in the same way that sports knee surgery is a subspecialty of knee surgery. You get people like this fella who had septicemia in Scotland, who was looked after intensive care, and he lost the tips of his fingers. He was a bagpipe player, and he has, through his own determination, managed to return to playing bagpipes. I saw his story in the Daily Mail. It's in the public domain. I'm sure he wouldn't mind me referring to it. It's a truly remarkable story, and musicians are really remarkable in how they return to playing music with such determination when things seem to be stacked up against them. If you're a musician, you'll know that being a musician isn't really like having a proper job, as it's called, in the sense that it becomes part of your identity as well as being part of your livelihood if you're a professional musician. And it's really difficult if you can't do it anymore. It's the only occupation I see people with who actually cry frequently in my clinic when it becomes clear that they can't do their music anymore. It's quite normal to get through quite a few boxes of tissues in my clinic, unfortunately. Now, the subject has been around for a while. Raoul Tubiana popularized it in Paris in the 1970s. Ian Winspur and Kitwin Parry did a huge amount of work in the 1990s to get it going in Britain, setting up the British Association of Performance Arts Medicine and writing the book on the top left, which was then followed up last year with a second edition that you see on the top right. And other people have also, the Brand from Brenners and others have done a tremendous amount of work internationally to turn this into a proper subspecialty. However, it is still a small group of people who work in this field. There are about 200 hand surgeons working in the UK. I've now used lockdown to form a group of about 10 hand surgeons who have expressed an interest in particularly wanting to look after musicians for all the special problems that I'm going to cover in this talk that musicians have. And a large number of hand surgeons don't want to do this work for a lot of obvious reasons, which we'll cover in the talk. So I got into this then by leaving the NHS after over 20 years in the NHS. I worked as a consultant at King's for 14 years and did lots of trauma, and then became a hand specialist after doing a hand fellowship many years ago at East Grinstead. And I decided I couldn't apologize to people 20 times a day anymore working in the NHS, so I decided to just work in the private sector. And that meant that I didn't have enough work to keep me busy all week. I was working in central London, and I'd heard that there was a busy hand clinic in Hendon, and John White was very gracious and kind to me when I went there. And it fitted his agenda perfectly. He had a plan to go back to Australia, and when he heard that I was an amateur trumpet player, he thought that this would be perfect for me. So I inherited his practice. I didn't at that stage know that musicians' hands was a subspecialty of hand surgery, after being a hand surgeon for about 14 years. And I thought, what does that really involve? And then I began to learn 4 years ago, and it's been a very quick learning curve for me. So that's Hendon Hospital. And this is John White up here on the right. And this is the great Ian Winspur, who has written these textbooks on the subject, and is also an inspiring chap, who was allowed to retire at the age of 75 last year, but still stays in touch with me and often gives me tips, and I try to suck as much information out of him as I can whenever I meet him. This is me being stupid, mucking about with my band in a pub, and I think it really was, when they saw that I was a musician, I think they thought, oh, this is good. John White's a very accomplished percussionist himself. The first thing I did was join BAPAM as a practitioner for BAPAM. BAPAM they've now got a new website actually. So if you go to bapam.org.uk, you'll find their new website. It's a fabulous new website, and they're a great organization. They are based in London, but they have hubs around the UK. They are great for many things, including being able to triage patients and signpost performance arts people with medical problems to the services that are available nationally. And they really do that very, very well. And they're largely sponsored by these organizations at the bottom, and it is a charitable organization. Consultations are free, but people only get one, and then there has to be an ongoing treatment plan. Unfortunately, I have one of those. I have an ongoing treatment strategy. So, what have I learned? Well, I've learned that actually to be able to talk in the language of a musician, as soon as somebody says that they say they play the small saxophone and I say the alto, or I say that I play in bands, they know that I'll know the relative hand positions and how a saxophone is held, or talk about traditional grip on drums versus parallel grip, German and French grips, and a lot of things like thumb stop positions on the cello that I've learned in the last 3 years. And I can see those in practice when I play in my band or I go to concerts. And I look really closely now to look at the sorts of things that musicians do habitually when they're playing. And I look very carefully with an eye that possibly other people don't have. In fact, I've talked to musicians who played in orchestras for a very long time, and I talked to a violinist who didn't really know how you hold a trumpet. He didn't know which hand did the work, or where the support on the trumpet was. Of course, it's held largely by these little rings here, a little ring on the little finger, and underneath this bar here, and you can hold a trumpet one-handed. But of course, people use it two hands, and then use this slide on here. And it's little gadgets like this slide and things like that, or the octave key on the clarinet, or a thumb post for the clarinet. It's useful to know about those things when you're treating musicians. And the jargon can sometimes be a bit much if somebody isn't a musician, I think. So it helps being a performer myself. And then the next people often ask me the next question, which is, what problems do musicians get? And of course, they get the same problems that everybody else gets. They get fractures, they get carpal tunnel syndrome, they get trigger finger ganglions, neuromas, and they have fractures and tendonitis. And I would say about half my patients come in the category of, I've got a problem that everybody else gets, but it affects my playing really badly because I need my hands. And they often come very early in their presentation with that problem as well, and we'll go into a little bit of that later on. But the other half of the patients come with instrument-specific problems, and I'm starting to see that much more commonly. You see things like neuromas on the fingertip of a cellist or a violinist. You'll see a neuroma on the side of the finger in a guitarist, doing bar chords, or perhaps in a flautist suspending the flute on that part of the radial digital nerve, which is the most vulnerable one. And those are typical sort of problems. I mean, thumb problems in clarinetists, supporting the clarinet on the thumb. And these are all very instrument specific, and I see them regularly now. I see about 6 or 7 new musicians a week. Well, I did before lockdown, but now things are gradually building again. And they also have problems that go beyond the hands to do with their general health, etc., which everybody's aware of. What's the demographic of these patients then? Well, it's mostly, in fact, from Ian Winsper's book, his work over 25 years, he's summarized all of that, and it seems that he mostly sees guitarists, violinists, and pianists, and that's my practice too. In fact, my feeling is I think I see more guitarists than anything else. And that's why it's really good that I work with Paul Anders Sogard on that. But I have other musicians that I work with in different fields, including Penelope Roskell on the piano, who's also really an excellent collaborator with me. And from Ian's book, and I think this is about right, I think the problems that come to me are about 20% guitar, 20% violin, 20% piano. The next instrument is probably the cello, and then the most disproportionately represented instrument is the harp. I think there's also reasons for that. Apart from the physical demands playing the harp, there's tuning before playing the harp, which apparently needs to be done every time the instrument is moved, and it's quite arduous. Carrying the harp around, of course, it's a huge thing, and I think that we see quite a lot of harpists, considering how few harpists there are in the world. These are people with very busy hands, and they have tendonitis because tendons fail regularly if they do things that they aren't accustomed to. And that's when we see people come to the clinic. It tends to be when there's been a step change in how much somebody's playing. They've got a new instrument with a new action on it, or they've got a big concert coming up, or some exams to do, or they've left secondary school with 2 hours of practice a day and they've gone on to a conservatoire where they're doing about 6 hours of practice a day. And suddenly their ligaments fail because they're doing much more work than they were. Changing the repertoire, that sort of thing. I mostly see professional performers, quite a lot of students. A lot of students have problems when they first arrive at conservatoire because of that step change, and then they get a little bit more comfortable as they get habituated to playing for longer hours. See many teachers, particularly during lockdown, a lot of musicians have continued to teach or teaching more on Zoom, and I see some amateur musicians as well. And when I ask people how much they practice, and I ask everybody how much they practice, it seems that people practice a huge range of differences in amount of practice per day. Quite a lot of musicians will play for 1 to 2 hours a day. Some people will do a lot of practice and do 6 to 8 hours, some even more than that. And then we often see freelance musicians who will play not at all for a few weeks and then play 6 to 8 hours a day when they need to. And that causes problems at that interface between not playing and suddenly playing again, because the background fitness tends to disappear a little bit. And I was a bit shocked to discover that musicians have absolutely no plan to retire, which is a bit shocking. Why are performers different to people who aren't performers? Well, essentially, the hand is probably the most common failing organ that presents to the British Association of Performance Arts Medicine, because it is the most vital thing for playing music, and most patients that come to the BAPAM clinic are musicians. There's about 70%. The rest are dancers and circus artists, etc., gymnasts. And when your performance drops very slightly, you can't do it anymore, and your hand only has to be impaired very, very subtly to need to come and see a doctor. So a lot of people who have a minor problem with their hand, very minor carpal tunnel syndrome or minor trigger finger or minor Dupuytren's contracture, will be able to carry on typing or do their sport, run, play football, and they present much later when the problem in the hand is much more severe. The next thing that performers find is that they want a very high standard. So for a very mild degree of compromise of their hand, they'll want to make sure that they get absolutely back up to full performance very quickly. And before lockdown, there was no opportunity to operate on musicians because they couldn't stop work, because they usually aren't paid as they would deserve to be paid, and can't afford to take time off to have surgery. And certainly the risks are extremely high in that situation. So, so high demand, early compromise, high expectations of outcome, and difficulties with not being able to stop work ever, either during their working life or and not retiring. So they're different for lots of reasons. So when I take a history from patients, I'm often asking about their rehearsal and performance, and whether we can intervene. And we have to chat about how to plan an intervention. And then we talk about what are the best techniques around that, and how we can modify our intervention to suit them. In fact, I only operate on about 1 in 10, or maybe 1 in 8 of my patients, something like that. For the most part, we can keep people going with hand therapy and steroid injections. I've said here 5% of new patients. I think it's probably a little bit more than that, actually. But most people don't have surgery. You might need to, if you are going to do surgery, you need to think about where your incision is going to be to see that it doesn't interfere with maybe the point of contact of the string, or if you're fusing a finger joint, which is the optimum joint position to fuse it in. How much pinch grip can you get for a guitarist's left thumb after a trapeziectomy for a thumb base arthritis? If you do a trigger finger release, will you compromise the ability to reduce fret buzz when you press on the strings? Dupotrons in pianists, their reach to get a 10th may be compromised. They may only be able to reach a 9th once the Dupotron's contractors pull their finger in. And so you might be dealing with very mild Dupotron's contracture. So you have to do this thing slightly differently for people. Talking about understanding the interface, you need to understand the difference between maybe bagpipes, where you play with the pulp of the second phalanx on the chanter, to Northumbrian pipes, where you play very much on the tip of the fingers. So you need to understand the interface like that. And there's quite a lot of studies to look at how people recover thumb pinch strength in guitarists. To get a good timbre on the guitar, you need to have good pinch strength. And a trapeziectomy is to take out the bone here at the base of the thumb. And there's data out there where you can look at grip power in males and females, and pinch power in different age groups. So you have the background demographic, and then you can do studies to look at how much pinch strength is recovered following the trapeziectomy before the surgery, grip strength coming up slowly after the surgery, 12 months. And here you see with different types of surgery, trapeziectomy alone or trapeziectomy plus ligament reconstruction and tendon interposition. But you see it's a long old recovery to getting your pinch strength back up. So because I work in London Sports Orthopaedics, I work with sports physicians, and many of them work in teams with, say, in tennis or in rugby. And I've realized that within those elite sports, I went to a symposium with Mike Hayton, who basically treats a lot of elite sportsmen in the UK, in the Manchester area, for hand problems, boxing commonly, and climbing and tennis, racket sports, and other elite sports such as Red Bull High Performance. And he worked, and from a symposium that Mike organized, I realized that a lot of these people at the very top level will have a sport-specific physician looking after them who knows everything about that sport, the kind of medical problems that happen in that sport. They'll also have a coach from that sport that, of course, understands the sport intimately. They'll also have a therapist within that sport. So if they're a tennis physiotherapist, they'll be highly specialized in terms of the typical problems that tennis players or climbers get within their own field. And I've realized that really that doesn't exist in performance arts medicine, at least in the UK, and I don't think very much in the world, this concept of having three specialist physicians, therapists, and technique tutors working together. And this Venn diagram is meant to show how there's an area in the middle here where the knowledge for each of these people overlaps. There may be some knowledge between the physician and the therapist that the coach doesn't have, for example. And we're trying to get systems going, and lockdown's been great for this. We've had 4-way Zoom sessions with musician, teacher, educator, therapist, and me, sitting in and learning from each other in a way that we haven't been able to do before. You can use Zoom in such a way that you don't need to be in the patient. So you have a large instrument like drums, piano, church organ, harp. It's very difficult to bring these in, whereas often the educator and the musician would have these in their house. They'd be in their own little windows on Zoom, and then you've got me and the hand therapist listening in, all learning from each other about what the clinical problem is, where the workaround may be, or what workarounds are possible, how that fits in with physiotherapy. And the output of the exercise might be that they need more hand therapy, more surgery, more technique modification, or perhaps a bit of all of those things. And I've found them extremely useful. So we're doing a lot of that now. So I've been using a lot of videos, and the joint clinics are now moving, during lockdown, they've been moving into becoming my main tool for triaging patients from around the country, and in fact from around the world. And they've also become really useful for bringing in either somebody's parents or their own teacher into the consultation as well. And they don't have to be in the same location, they can be quite far away. Doesn't matter where in the world they are. And we can bring in tutors and educators from around the world. We can even bring in hand therapists from around the world to look at cases. And our world has suddenly become a lot smaller through video conferencing. So one of the upsides of lockdown. We see lots of conditions like this. Focal dystonia is a massive problem. We could do a whole talk on that. Catherine Butler has done a huge amount of work on this. She's a London-based hand therapist that's been dedicating herself towards musicians. She's a flautist herself. She's been working with the original founders of BAPAM, Kitwin Parry and Ian Winspur since the very beginning, back in the 1990s. And her website has a huge number of publications on it and research work. She herself has done about 150 patients with, she's come to know about 150 patients with musicians' focal dystonia, and done some work using functional MRI with Queen Square and with Professor Mark Edwards down at St. George's. And essentially, it's clear that this condition is largely a software problem rather than a mechanical problem. Sometimes it follows a mechanical problem and then becomes a secondary focal dystonia. And in order to retrain the software to do all of those automatic things that many years of practice have led to just running off scales, running off licks, running off different phrases. They don't run anymore once you have focal dystonia, and you have to relearn them very slowly. And it's a lengthy process that may take a year or two of dedicated treatment involving different pathways, slow down techniques, distraction techniques, desensitization, changing the sensory input, using mirrors. There's a number of different, splinting, strapping, and working very hard on all of those things, technique workarounds, etc. Yes, I've talked about this already. One of the first things I noticed when I started doing this kind of work is just how hard patients were prepared to work on their hand therapy. In my previous life as a hand surgeon, I'd tell patients to do 10 minutes exercises a day. they'd forget, they'd go back to work and they'd forget to do their exercises. If a musician does 4 or 6 hours of hand therapy, 4 or 6 hours of practice a day, and they can't do any practice at all now, they will do 4 or 6 hours of hand therapy in order to get back to playing their music. The motivation is quite unlike any other group of patients I've ever looked after. And then you see people like Django Reinhardt and Tony Iommi. I've got some pictures of them in a minute. They basically are determined to carry on being musicians despite the fact they've burned their fingers. So, yeah, Django Reinhardt, who became one of the world's greatest gypsy guitarists. You can see him playing here. Amazing, just 2 fingers. And then Tony Iommi, of course, Black Sabbath, burned his fingertips off and managed to get these prostheses made and develop a new genre of music, basically the power chord that led to the style of Black Sabbath. It's marvelous. I went to the O2 to see them play a few years ago. Love it. Yeah, and then you have people like Angus, whose posture, perhaps I think the previous screen was meant to show posture, but it's there's lots of different postures playing guitar. Of course, you can rehearse with the guitar on your left knee, on your right knee, with a strap, without a strap, without a foot support, with a foot support. Different postures for different styles: flamenco, classical, rock, folk music, thumb over the top. But yeah, all like you can play like this lying down. We talked a little bit about common problems already. Carrying instruments, of course, is a big issue. You can adapt your instruments. This is a video of an adaptive flute. Of course, the flute's a very asymmetric instrument, but it causes lots of problems with pressure on the digital nerve of the left index finger. As I said earlier on, that's a good workaround for that. You can actually change the shape of an instrument, or you can have extensions on some of the levers to make it a little easier to play certain notes based on your injury or disability. So, as an amputation, partial amputation of your finger, you may have to have the instrument adapted. So in summary then, this is a joyful and wonderful group of patients to look after, very demanding with very good reason. I think sometimes the demands are so great that surgeons find this an intimidating field of patients to treat. I enjoy rising to the challenge. All musicians are by definition very intelligent, and I really enjoy looking after musicians. Same problems as everybody else, but essentially the effects are greater on them. I do a little blog on my website, musicianshandclinic.co.uk. There's a blog on there called the 5 S's, and I talk about the 5 things that musicians notice much sooner than others. So that's span, if their span is reduced, or their strength is reduced, or their sensitivity is reduced, or their stamina, or their speed is reduced at all, they'll notice it straight away. In fact, there's a little strategy that Tubiana came up with, and I've adapted it a little bit back from the 1970s. It's a 5-point classification system that goes 5 down to 0. You're a Tubiana 5 if you've got a problem with your hand and you're a musician, but you can still practice and perform as much as you like. You're a 4 if you start to compromise on your practice, but nobody else has noticed yet. So you can still perform in public and you're not cancelling gigs. A 3 is when you're cancelling gigs or somebody thinks your performance isn't as good as it was. And a 2 is when you're not performing in public at all. And a 1 is when you can barely practice at all. And a 0 is when you can't even practice. And people come down that scale at different stages. And depending where you are on that, different interventions will be used accordingly. and if you can't play at all after an injury, then of course there's an opportunity to make you better with an intervention that's going to keep you off for a while. You have to choose how interventionalist you need to be on that. It may be that you can find workarounds with the instrument itself or a technique modification, and the hand therapists, maybe a hand therapist, a specialist physiotherapists who just do hands once they've done the hand diploma. And within that group, many of them are interested in looking after musicians. I've got a large network of musicians, interested hand therapists now around London. So it's a highly specialised field of physiotherapy or occupational therapy. And that Holy Trinity approach, I talked about having a some sort of therapist and a trainer or an educationalist, coach, and me. I think in sport, it's very important to have a psychologist available if you need a psychologist too, and that works really well too. So it's more than a Holy Trinity; it's a Holy Fornity, whatever it is. Yeah, that's pretty much all I had to say on this, and I can do a question and answer session on the back end of this if necessary. I hope you found that helpful. Cool.